So this topic is mechanisms of failure of the INPACT Admiral DCB platform, pooled analysis. So I have no relevant disclosures to declare. In the past, we conducted several studies comparing DCBs with PTA and showed favorable outcomes with using DCBs over PTA. And the favorable outcomes were reported up to 5 years, even in more complex lesions. There is body of evidence on the predictors of DCB efficacy and failure mechanisms in the coronary world, especially when it comes to ISR. However, question remains regarding clinical, anatomical, and procedural factors associated with DCB outcomes in patients with PAD. Here is a table with several previously performed studies, all of a small sample size, as you can see here, 50, 87, 170, 109, and 91 patients. And the clinical, anatomical, and procedural characteristics were included in those analyses were of limited number. But those studies highlighted also already several risk factors which might be associated with less efficacy of DCB use. However, based on the fact that those studies were small sized in general, multivariate analysis was not quite comprehensively doable in those studies, and there might be factors which were underappreciated because they were not examined in those studies. So to evaluate predictors of DCB outcomes, we used a large, rigorously adjudicated with core lab adjudication and clinical event committee adjudication database from the INPACT Admiral platform. We pooled data from two registries, the INPACT Global Long Lesions and INPACT Global CTO Imaging subcohort, together with two randomized clinical trials where we took only the DCB cohort out of those trials, the DCB, INPACT DCB Japan and EU and US studies. We pooled those data. We were looking for clinical, anatomical, and procedural characteristics associated with DCB failure. Our endpoints were defined as clinical-driven target lesion revascularization, binary restenosis, and failure of primary patency. So the pooling of the data resulted in a total number of 557 patients. And we examined, as you can see here, a huge variety of clinical, anatomical, and procedural characteristics which were used in those prospective studies. So we used a multivariable Cox regression model, and the entry criteria was quite rigorous with every variable which was significant up to a level of less than 0.2 of p-value and had no more than 20% missing data were included, and our focus was clinical and procedural relevant characteristics. So here are the baseline clinical characteristics of the pooled patient population: age in the late 60s, predominantly male patients with extensive cardiovascular risk factors. Almost half of them had coronary artery disease and 1/4 carotid artery disease. And as you can see here, Rutherford category over 3 was only in a minority of cases, which were mostly ischemic resting pain and a few tissue loss, Rutherford 5 patients. The baseline lesion characteristics are described here. De novo lesion in the majority of the cases, lesion length in mean at 16.4 centimeters, reference vessel diameter 4.7 millimeters. And half of those patients had CTOs, and severe calcification was over 55% of cases. And here are the procedural characteristics: a true lumen cross in 80.4%. Most of the patients got pre-dilated. And as you can see here, also dissections occurred in 20% of the cases, and residual stenosis over 30% was reported in 12.8%. Provisional stenting was used in almost a quarter of the patients, and this applied mostly on the higher length tersile patients, as you can see here. This study was not conducted for safety and effectiveness outcomes, but for completeness sake, I'm presenting the primary patency at 1 year at 82%, freedom of CD-TLR with 94.7%, freedom of binary restenosis 84.5%, and the freedom of primary safety endpoint was 93.8%. And here comes the more important analysis which we performed, the multivariable predictors of clinical-driven target lesion revascularization. In the multivariable analysis, only residual stenosis and Rutherford category over 3 were predictors of CD-TLR, while all other clinical, anatomical, and procedural characteristics were not. Similarly was the case for binary restenosis. Here again, residual stenosis of over 30% and a smaller pre-procedural reference vessel diameter were predictors, significant predictors of binary restenosis, while all other parameters remained negative. For failure of primary patency, we have a similar outcome. Here, only residual stenosis of over 30% was an independent predictor of this endpoint, while all other parameters were not. So when we look at the addition of those risk factors together and their influence on the occurrence of endpoints, we see here for CD-TLR, if you have none of the risk factors, you have only 3% chance of TLR, while it goes up when you have one risk factors to up to 12%. And if you have both risk factors, 1/3 of those patients would come back for a TLR. Similarly is the case for binary restenosis. If you have none of the risk factors, you have a chance of 9% of a restenosis, while when you have one of the two risk factors, you will have up to 20%, almost 20% risk of binary restenosis, and it doubles when you have both risk factors on board. So in conclusion, this large empirically driven evaluation of DCB outcomes using a broad set of clinical, anatomical, and procedural characteristics showed that DCB works in the majority in a wide range of clinical anatomical scenarios. Patency can be optimized by procedural factors, which are mainly in the hand of the treating operator. And with the major focus should be leaving a residual stenosis of less than 30%. This analysis has certain limitations which have to be acknowledged. We investigated only the INPACT Admiral DCB patient cohort, so our findings do not apply to all other platforms automatically. And also, this is the largest data set analyzed. It's still relatively underpowered, and it would be great if we can pool all the data from all DCB platforms together and perform a similar analysis to find an algorithm of clinical, anatomical, and procedural factors which might be associated with less DCB efficacy. With this note, I would like to inform or share with you that this paper got accepted recently at JAC and went online a couple of days ago, and I'm proud to have served on this manuscript as well. Thank you very much.